Next presentation is by Hamid Shah and Kevin Foley. Paper talks about long-term outcome of minimally invasive transforaminal lumbar interbody fusions, 5-year post-op and beyond.
Hello, good afternoon. I'd like to thank everyone and the scientific committee for having me present this work. This is a... Oh, I'm sorry. Can you hear me now? This was work that was done while I was a fellow with Dr. Kevin Foley. These are our disclosures. I have none. Dr. Foley has several. Why am I even thinking about this? There's concerns regarding the rising cost of healthcare in the U.S. This has led to a great interest in determining how to spend healthcare dollars wisely. As Dr. McGirt had spoken about earlier, the cost of spine care has come under increasing scrutiny. We're spending now $90 billion a year on spine care alone. Over the past decade, the cost of spine care has increased 65%, while the incidence of spine pathology has increased only 34%. What we do know, though, is that spinal procedures can improve quality of life for a sustained period of time, and what we need to now demonstrate is that they can meet a cost-effectiveness criteria. Concurrent with the rising concerns regarding the cost-effectiveness of spine care, new spinal surgical techniques have evolved as well. Minimally invasive TLIF, or transforaminal lumbar interbody fusions, are one of them. There are a few studies that have addressed the clinical efficacy of minimally invasive TLIFs in the midterm, and currently there are none that have looked at it over the long term. So the way this study was constructed is it's a retrospective review of prospectively collected data. We obtained IRB approval and reviewed charts for patients that had undergone a single-level minimally invasive TLIF 5 or more years previously. All cases had baseline preoperative oswestry disability indices as well as visual analog scores for the back as well as for the leg. Patients were contacted by phone and invited to participate. They were sent visual analog scores and oswestry questionnaires by mail. This data was then tabulated and compared to the preoperative scores. Specifically for the VAS scales that we use a 100 millimeter horizontal line, 0 equaling no pain and 100 equaling very severe pain. We use this both for low back pain as well as for leg pain. The oswestry scale we used had a breakpoint of 40 to 60 for severe disability. In normal controls, the oswestry score that we used was 10. This was reported by Fairbank. In the study, we had 53 patients that were identified. Of those, 37 were successfully contacted and included in the study. All patients had a current oswestry disability score obtained. All patients had back pain and leg pain scored preoperatively and then postoperatively at the remote time. All patients underwent a single-level minimally invasive TLIF. All had peak interbody devices, and all had percutaneous bilateral pedicle screw fixation. And this is the results of the study. There were 17 men, 20 females. Mean age was 63 years. Mean follow-up was 72.6 months with a range of 60 to 90 months. 12 patients underwent L5 to S1 fusion. 25 patients underwent L4-5. 24 patients had grade 1 or grade 2 myroding spondylolisthesis. 1 patient had a grade 3 myroding spondylolisthesis. 12 patients had no spondylolisthesis but had signs and symptoms consistent with mechanical back pain with leg pain secondary to a symptomatic degenerative disc disease. 33 patients had a unilateral decompression and 4 bilateral decompressions. This is the tabular result of those. There was a mean pre-op ODI of 53, and for the VAS scores was 50 and 56 respectively for back and leg. And the final post-op scores were 17 for ODI and 12 and 16 respectively for back and leg VAS scores. These all had statistical significance. This is a graphical representation of that table. As a reminder, 40 to 60 was considered severe disability. Preoperatively, all these patients did appear to have a severe disability, and postoperatively, their scores were 17, which falls into the minimal disability score. Again, normal controls is 10 on the oswestry score. So as I was thinking about why do we even consider justifying minimally invasive fusions, we have to look at justifying open fusions first, and a study by Moeller and Hedlund in 2000 reviewed open posterolateral fusions in adult spondylolisthesis and demonstrated that there was a significant improvement in outcomes at 2 years compared to a non-operative exercise program. These are the scores here. For the patients that had surgery, their pain index score improved from 63 to 37, whereas the non-operative score was 65 to 56, and these two groups had a statistically significant difference. Subsequently, Moeller and Hedlund reviewed the long-term outcomes on these same patients over a range of 5 to 13 years, and it was demonstrated that these patients had a persistent improvement in their outcomes. But what they also noted was that there was a slight worsening in their scores over this period of time as well. The open TLIF has been an accepted alternative to a posterolateral fusion. Hackenberg and all reviewed the midterm outcomes of 52 patients who had undergone an open TLIF procedure, and you can see here in their preoperative scores they all had a significant amount of disability, and immediately postoperatively they all had a meaningful improvement that was statistically significant. And if you look at the range of these patients, there was an average follow-up of 46 months with 3 to 5 years being their range. There was a trend towards a worsening in their outcomes as well. It's suspected a lot of this outcomes is from the extensive muscle dissection that is required for open procedures, and Foley et al. In 2003 directly addressed this by describing the minimally invasive TLIF and its feasibility in 12 patients. Schwinder et al. In 2005 then looked at the 2-year midterm outcomes in 49 of these patients. The mean follow-up for this group was 22.6 months. The mean pre-op VAS was 72 millimeters, and the pre-op ODI was 46. The post-op scores were 21 for the VAS and 14 for the ODI, so they started off with quite a bit of disability and quite a bit of pain, and ended near normal scores. So this was in the open groups, this was in the minimally invasive groups. So the next question in my mind was, how do they compare when it's head-to-head, open versus MIS? Well, Wang in 2010 did a head-to-head comparison of the midterm outcomes in 85 patients. 42 of them underwent a one-level open MIS TLIF, and 43 of them underwent an open TLIF. 42 underwent a one-level MIS TLIF, 43 underwent an open TLIF. They had a minimum of 13-month follow-up, and what you can see here is in the long end of the follow-up, there's a very negligible difference in the ODIs between the open group and the minimally invasive group, and they started off fairly similarly. There is a significant difference here immediately post-op between the scores, and it translated into an early mobilization for the patients. So as we were thinking through this, these scores were very interesting just from a specific patient point of view, but it was very difficult to generalize this, and so then we started looking at how to generalize this, and in the quality adjusted life years was the most reasonable way to start comparing these results. And what the quality is it's a composite index that takes into account the benefit of a therapy and the duration of that benefit. You can use a cost per quality calculation then to define the relative cost effectiveness of the various treatments. In general, surgical procedures that produce a long-lasting clinical benefit should yield improved cost per quality ratios compared to procedures with shorter durations of benefit. And in order to be considered cost efficient, a procedure must have a cost per quality ratio below $80,000 per quality. And it's interesting, Toteson originally in the sport trials discussed lumbar fusions and demonstrated that at that time they were not cost efficient. Since then, several studies have been undertaken that contradict that statement, and actually a reanalysis of the sport trial demonstrated that even in that group, the spinal fusion group had a cost efficiency as well. Glassman et al. Demonstrated a cost efficiency of 5 years after surgery for open posterolateral fusions. McGirt et al. Then did a similar study for 2 years looking at open T-lifts, which also demonstrated a cost efficiency for that procedure. They then compared MIS T-lifts with open T-lifts at the 2 years in a study by Parker et al. And they looked at 30 patients. 15 of them underwent a MIS T-lift and 15 of them underwent an open T-lift. And what they noted was that they had a similar cumulative 2-year improvement in qualities over this period of time, and they also had a similar cost over this period of time. And one thing of interest was that their pre-op ODIs were 36.9 and their post-op ODIs were 15.7. If you compare our results of a pre-op ODI of 53 to a post-op ODI of 17, and our results are over a 6-year period of time, it would lend itself to think that if we were to actually be able to do our cost per quality analysis, that this cost per quality analysis would be very similar to the Parker outcomes as well. So in conclusion, minimally invasive TLIF is an effective means of addressing low back pain as well as leg pain due to spondylolisthesis and degenerative disc disease. Previous studies confirm equivalency to open procedures. This is the first study with 60-month or greater than 60-month follow-up demonstrating long-term durability of MIS TLIF results. These results do need to be corroborated by data from other centers, and the long-term improvements of patient-derived outcomes has positive implications for cost-effectiveness of MIS TLIFs.